Good afternoon. My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN Project. And thank you all for joining us today, and our friends at La Clínica de la Raza in the San Francisco Bay Area for hosting today's session. Our session today is Successful Management of Gout in the Primary Care Setting with Dr. Robert Goldfien. Dr. Goldfien worked as a rheumatologist at Kaiser Permanente for over 28 years. In addition to his clinical practice, he held roles as Chief of Medicine at Kaiser Richmond, Chief of Rheumatology for Kaiser East Bay, and Chair of Rheumatology for the Permanente Medical Group. He is currently consulting in rheumatology at 2 community clinics in San Francisco and Marin County, California, and he has an interest in inflammatory arthritis and in the management of gout. It's a pleasure to have you here today, and I'll turn it over to you.
Thanks, Joe. Can you hear me? We're okay, good. Well, I'm glad to have the opportunity to talk with you about management of gout in primary care. This has been a longstanding interest of mine, in part because I did a lot of primary care in my time at Kaiser, and I helped the primary care department develop some chronic disease management programs. And it became obvious to me at some point that gout is not unlike some other chronic metabolic diseases that primary care docs take care of. And it's something that can be done pretty straightforwardly through primary care. So let's go. I have no disclosures. This is our accreditation information. Learning objectives. So I hope you'll come out of this meeting today with an understanding of prevalence and risk factors for gout, be able to recognize gout as a chronic metabolic disorder, and to think a little more clearly about management of acute gout as distinguished from management of chronic gout and hyperuricemia. And finally, I'm going to try to leave you with an approach to managing gout that you can do in primary care very successfully. No, it's not. Okay. First of all, just to be clear about what gout is. So gout, we think of it as a form of arthritis, and it certainly is. I prefer to think of it as a chronic condition where hyperuricemia leads to an accumulation of crystals of sodium urate in the joints and other soft tissues. It does present typically as an acute and often self-limited monoarthritis, which we usually call a gout flare. Most commonly in the first MTP joint, but it can occur in other joints, especially in the lower extremities. In many cases, it starts as a very infrequent acute flare, but becomes a little more bothersome and more frequent with time as the uric acid crystals accumulate in the joints. And in severe cases, tophi may occur. Among the kinds of arthritis that we see, inflammatory arthritis, gout is the most common one in men, and it has a male to female predominance of 3-to-1, unlike other forms of arthritis. It does increase in incidence with age, and its incidence varies worldwide. But the incidence worldwide has also increased a lot in the past 30 years, and there's been a lot written about this. To understand that, it helps to understand the comorbidities with gout, and some of these are listed below. About 3/4 of people with gout have hypertension, probably about 30% diabetes, and another 30% have chronic kidney disease. And these comorbidities have been seen over and over again in studies. And so I think it's important to point out that gout is no longer a rich person's disease as it once was thought of. It's really now a disease of people with other comorbidities that tend to lead to hyperuricemia, which are the ones listed here mainly. All of these conditions are associated with hyperuricemia. So I'd like to talk a little bit about diet and gout. I don't focus a lot of my attention in my gout patients on diet in my gout patients, but my patients do. And all gout patients will ask me about their diet and what they should avoid and eat. So what I like to tell them is that there are foods that increase uric acid. Seafood, organ meats, and alcohol are commonly thought of, as well as high fructose corn syrup. So people who drink soft drinks, should be told that can increase uric acid. Legumes have been implicated in having a lot of uric acid, but I don't think they've ever been shown to increase gout flares. So I don't tell people they have to avoid legumes. Among foods that lower uric acid, probably the main one that you'll see is dairy foods. But importantly, dietary intervention has limited effect on serum uric acid levels. And what I try to tell my patients is to think of their diet as a trigger of gout, but not really the underlying cause. So it is true that if you go to a crab feed, you might get a gout attack, or if you overdrink. But if you didn't have a high uric acid to start with chronically, then that wouldn't cause a gout attack. So I try to make sure my patients understand that management of gout can involve some dietary intervention, but that alone usually isn't enough to fix the problem. Diagnosing gout, in most cases, is not difficult. It's often a clinical diagnosis. We do talk about aspirating joints and looking at crystals under the polarized light microscopy, but it's not always practical. If someone comes in with their big toe swollen, I don't try to stick a needle in it usually. And if they turn out to have high uric acid or other comorbidities, you can generally diagnose gout with some confidence. At the time of presentation, serum uric acid may be normal, but it's almost always high in untreated gout. One thing to keep in mind there is, I think labs are better at this now, but during most of my career, if you looked at the normal level of gout as listed in the lab results, it may say a normal uric acid could be as high as 7.5 or 8. That is based on the distribution in the population, just taking a normal distribution and 2 standard deviations. It's not based on physiology, which tells us that if the uric acid level is higher than about 6 or 6.5, crystals can form. So just be aware that if you see a serum uric acid listed as normal, but it's 7.5, that's not really normal. We look for acute episodic flares to define gout. And typically, one thing that distinguishes gout from other forms of monoarthritis is that they really are discrete flares, and usually the joints normalize between episodes. And those episodes can be months to years apart in some cases. So typical acute, usually resolving pain, and then no symptoms in between. I'm mentioning radiographs and ultrasound and CT just to let you know that, there are ultrasound and CT tests that can be, or findings that can be diagnosed of gout, but they're not widely available. Radiographs will only show typical findings of gout in fairly advanced cases. So a normal X-ray doesn't rule out gout. Again, family history, comorbidities, and triggering events are things to ask about in the history. And if there's a typical picture, you should go ahead and treat them. And just keep in mind that gout is rare in untreated people with serum uric acid less than about 6 or 6.5, though the levels can fluctuate some. Treating acute gouty arthritis in some ways is sort of simple, but there are some tips I think that can help. Treating the attack early and aggressively is important. It's a very highly inflammatory condition, and you really need to hit it with anti-inflammatories to get it under control before it sort of gets set in. Typically, the options for treating acute gout are the ones listed in here: NSAIDs, colchicine, oral steroids, and ice. And ice in capital letters. It turns out that applying ice to a gouty joint actually does help. There have been studies that have shown this, so that's something patients can do. Treatment options can be limited by comorbidities, for example, diabetes and CKD, which, as I showed above, are fairly common, but they don't have to be. It doesn't mean that treatments are contraindicated. It just means that it can be a little more complicated. You can give someone, for example, who has diabetes, steroids for a short course, but it's good to warn them that their sugar may go up, and you try to limit it. One pitfall that happens frequently, and as a rheumatologist, I see this because people whose gout is not being controlled get referred more frequently. Sometimes the patients stop the treatment too soon. And if you stop the anti-inflammatory treatment before the gout symptoms are gone or almost gone, they can sort of recur. I tend to explain it to my patients like a smoldering fire. If there's a little bit of smoldering and the wind comes up, the symptoms can come back. So you try to douse the symptoms with the treatment as soon as and aggressively as you can. Prednisone is really useful for treatment of gout. It's generally used when other treatments aren't working. Someone who's taken an NSAID for a few days and isn't getting better, or it starts to come back, you can put them on prednisone. I usually give people about 40 milligrams and then taper them over 7 to 10 days. And if someone's had several gout attacks persistent symptoms, you may have to treat them longer than 10 days. But it's a good idea to get them on a low dose after a few days, and then just you can continue it until the symptoms are gone. So NSAIDs, colchicine, steroids. More specifically, Indocin, indomethacin has been the traditional NSAID used in gout, but honestly, other NSAIDs work fine. Ibuprofen, naproxen. Mainly, the thing is to use full dose treatment initially and then taper. I would say in general for acute gout, a shorter acting NSAID is probably a little better because it will tend to have a more rapid onset. So for example, I wouldn't normally use meloxicam, which is a once a day treatment, but I might use ibuprofen or indomethacin. I mentioned prednisone before. Oral prednisone is highly effective. It can be a good choice if there's chronic kidney disease or NSAIDs not tolerated. Or again, if you've been treating someone and they're not really getting controlled, switching them over to prednisone can often be the thing that can take care of it. And I mentioned my taper. I usually start with about 40 milligrams. It's sort of arbitrary, honestly, but that's usually high enough to control it, and then taper it every few days. Intra-articular steroids are effective. I don't use them for small joints, but you could use it for a knee joint, for example, if you wanted to avoid systemic treatment. They definitely work. Colchicine is another interesting story. Colchicine, as you probably know, has been used for centuries for treatment of gout. It was approved by the FDA in June of 2010. Oddly enough, FDA has gone through this process of formally approving old drugs that had been grandfathered in before. And so they commissioned a study to use colchicine to treat gout and showed that it was effective. But notably, they did change the recommendation. I grew up at a time when, the treatment of gout with colchicine was to treat them with 0.6 milligrams every hour until the symptoms were resolved or until there was persistent diarrhea. But the problem is that most people had side effects before the symptoms were completely gone. So now the FDA recommends 2 tablets at the onset of symptoms, 1 tablet an hour later, usually at 0.6 milligrams. And then you can use it twice a day for 2 to 3 days after that, unless there's a lot of CKD. And I do avoid colchicine in patients with CKD stage 4 or more. It can be quite toxic if it accumulates at high levels, as it can with CKD. So that would be a time to think in terms of using prednisone, for example. So colchicine, NSAIDs, and prednisone. I'd like to switch over now to the treatment of recurrent gout and hyperuricemia. And I'm going to sort of frame this in the following way. I like to think of gout as a chronic metabolic disease dressed up as arthritis. And because of that, successful management of gout requires a systematic, target-directed approach to lower uric acid, which will eventually lead to the elimination of gout attacks. One of the things I will talk to my patients about in helping them understand this is use the analogy of hyperlipidemia, which I think is a very good one. we treat hyperlipidemia with statins, and but we don't treat acute heart attacks with statins. We treat the underlying cause, and statins are very effective in lowering cholesterol. And the effect of taking it is not to help people with coronary disease feel better on a day-to-day basis, but it's to prevent heart attacks. You can think of treatment with urate-lowering drugs like allopurinol in an analogous way. We treat to lower the uric acid, not because someone is feeling gout symptoms at a particular time, but because it'll prevent not heart attacks, but gout attacks. So it's very analogous to treating hyperlipidemia. And I think sometimes telling people that helps them understand, because if they don't understand what the treatment of hyperuricemia is meant to do, what they'll typically do is just stop taking it. I'll show you some data on that and talk about that a little bit further down. So management of gout is like other chronic metabolic diseases, and it's not a episodic thing. So general principles with treating hyperuricemia are the following. Number one, the key to managing gout is to keep the uric acid under about 6 milligrams per deciliter. 6 milligrams per deciliter is about where uric acid stops being soluble in blood and starts forming crystals. So if you keep the level below that, people won't form more crystals, and eventually the crystals in the joints can get dissolved and leached out and eliminated in the urine. Just an aside, you might ask the question, do I need to treat hyperuricemia if someone's had a single gout attack? And, the answer to that question traditionally has been, not necessarily. If someone's had recurrent gout attacks, you should treat with urate lowering therapy, but maybe not after the first attack. I don't think that's really based on science. That's more kind of a practical thing. But anyone with recurrent gout attacks should be considered for urate lowering treatment as a long-term management. Urate lowering treatment is effective in almost all patients if it's dosed appropriately. And I'll get into the details of that in a way that I hope is practical for you. Although it's simple, the concept of lowering uric acid, in practice, it can be a little bit complicated, because when you initially lower the uric acid level, it's actually been shown that the gout patients actually have a slight increased incidence of flares when you lower uric acid treatments. Seems like the fluctuating levels going up or down can trigger gout attacks. So even though someone may be on the right treatment initially, they can still have gout attacks, and that's something it's important for them to understand, that that's not a failure of treatment. One of the things we can do in this circumstance is use something we call flare prophylaxis, and we can use colchicine or NSAIDs for that. And the idea there is, when you start someone on urate lowering treatment, usually allopurinol, you can also give them colchicine to take once a day, or even an NSAID to take once a day for the first few months, and that reduces the risk of flares. Colchicine used in this way will reduce the risk of flares by about 50%, although it can still happen. And that's good, because having flares after people are on treatment is confusing for patients. And I warn them when I put them on treatment, as the next bullet point shows, I warn them to be prepared that they can still have gout flares initially, but in the long run, the treatment will work. So especially the first 6 months or so, it's possible for people to have gout flares. If someone's uric acid level is below 6 consistently for a year or more, you mostly stop seeing people having gout flares. And one of the things I tell people, my patients, is that, the good thing about this is that once you've been on this medicine for a while, you won't have gout, and you shouldn't have gout for the rest of your life as long as you take the medicine. And, by the way, you can eat anything you want. Once you don't have any more uric acid crystals in your joints, you can't get gout by eating crab or shrimp or anything else. So it actually gives them the sort of, you can dangle the possibility for them to not worry about their diet once they're on adequate treatment. So Medication non-adherence is very common in gout patients, even more common than in a lot of other chronic conditions. And so you do need to monitor serum uric acid levels over time, especially initially. One other thing is I'm going to talk about using allopurinol. And allopurinol is definitely the first line treatment, but there is at least one precaution you should take, and that has to do with this gene called HLA-B5801. And it's tied into this thing we call allopurinol hypersensitivity syndrome. So if you've used allopurinol, you may be aware that there is a rare but potentially fatal allergic response that can happen to allopurinol. It resembles Stevens-Johnson syndrome, or what we now call DRESS syndrome, but it's a severe allergic reaction that can lead to rash, fever, liver disease, and organ failure. It's actually not common at all, but and it usually occurs in the first few months of treatment. But the risk is much higher in people with this gene, HLA-B5801. That is not a real common gene in the US population. It's more common in people of Chinese, Korean, and Thai ancestry. And so the American College of Rheumatology actually now recommends screening for HLA-B5801 in these populations. And then if you find that someone has that gene, we avoid allopurinol. So allopurinol is, there is this risk, but it's very small, and proper screening reduces the risk quite a bit. If someone has that drug, that gene, I'm sorry, we usually use febuxostat, which is a much newer urate lowering drug. It is also as effective as allopurinol. It happens to be newer and often much more costly. It may still be under patent, but it's no better than allopurinol in the general population. Okay. And finally, I do try to alert my patients who are getting allopurinol to report any rash or fever and stop the medication right away, since that probably can limit the severity of that allergic reaction. So specific recommendations for treating hyperuricemia, I'm going to list them here, and then I'm going to actually show you a more protocol structured approach that you can use in the clinic. We generally like to start people on a low dose of treatment. So in the case of allopurinol, that's usually 100 milligrams per day for the first 2 to 3 weeks. And then we titrate up by 100 milligram increments. There's two reasons for doing this. The first reason is I think that lowering the uric acid level more gradually leads to a lower rate of flares, and therefore it's less likely to have your treatment interrupted by having to deal with flares and explaining all that. The other thing is, some people don't need a higher dose to control their hyperuricemia. Most people do. I'll show you some data on that in a couple minutes. But after 2 to 3 weeks, you can titrate the dose up. And I do recommend getting a serum uric acid as a guide to that. I suppose a lot of people, you could increase them to 200 without checking, but generally you're going to take an approach that is increase the dose and then check the level and then decide what to do. Really important, the dose of allopurinol needs to be titrated up to achieve a serum uric acid of less than 6. I can't tell you how many times I had patients, especially patients with kidney disease, who were on 100 milligrams of allopurinol and their uric acid was still 11 or something. And, the problem with that is it's pretty useless. It's not going to prevent gout. And it turns out it's okay to titrate the dose even in people with kidney disease. So this is a target-directed treatment, just like you're going to use a target to decide if diabetes is well controlled or hypertension. You're going to use the serum uric acid to determine whether your urate lowering treatment is adequate. I mentioned febuxostat before. It's a newer treatment, but if you can't use allopurinol, you can start febuxostat 40 milligrams a day. I typically give people colchicine or sometimes just a small dose of an NSAID once per day for the first few months. It's not absolutely required, but as I noted before, there is at least one study that proves that taking flare prophylaxis does reduce the risk of flares and makes it just a smoother transition to the full dose treatment with with the allopurinol. If a gout flare does occur, and it will occur in some patients, it's important to tell the patient not to stop the urate lowering therapy. Don't stop the allopurinol if you get a gout attack. What you do is you treat the gout attack, and then you stay on the allopurinol. Okay? Because patients get confused. They often think that if they get a flare, they have to stop their allopurinol and start the other treatment, but that's not helpful. So I'm going to show you a protocol, and the background for this is when I was at Kaiser and seeing patients referred to me for gout, and I was aware of the chronic conditions management programs we had for other metabolic diseases. I sort of had this idea that this could be managed like these other chronic conditions. And at the time, we were using pharmacists to help the doctors in a lot of these conditions. So I talked my boss into letting me use a part-time pharmacist and started a referral clinic. And this was the structure of the program. It's called Gout Pharmacist Management because it was actually a clinical pharmacist I was working with to do this. What I did is I told the primary care doctors they could refer patients to my gout management program. And this was a over-the-phone treatment management program. And the way it worked was if a patient was referred, they would basically follow this schema. If they were having a gout flare, we would treat the gout flare with the things that I mentioned above. And if not, we would go straight to starting urate lowering treatment. And in this clinic, the default treatment was allopurinol 100 milligrams once a day. The next step was to wait 2 to 3 weeks and then check the serum uric acid level, just like I mentioned above for titrating. At that point, one of two things would happen. Their uric acid level would be at goal, and they would continue down on this schema, or they would loop back up to where it says start or titrate urate lowering therapy. So what that meant was the pharmacist would let them know their uric acid level was still above 6 and tell them to take 200 milligrams of allopurinol and then come back in 2 to 3 weeks to check the uric acid level again. And this cycle could be repeated until the uric acid level was less than 6. So that's what we did. Once the uric acid level was less than 6, at whatever dose that was, we would have them stay on that dose and then check the uric acid level again at 3 months. If it wasn't at goal, we would go back into the cycle of starting or titrating urate lowering therapy. It says discharge from clinic. This is because it was a referral clinic. In practice, in a primary care practice, you wouldn't discharge them, but you would put them on a sort of a more maintenance program, which means staying on the medicine and checking the uric acid periodically. You might ask, once they're controlled, once the uric acid level is less than 6, why check again in 3 months? And you'll see in the following slides why this is important. But just to preview, what happens is some percentage of these patients just stop taking the medicine at some point. And if they stop taking the medicine and you check their uric acid, what happens is it goes back up again. And then more or less they've stopped taking the treatment, and you can call them up and tell them to go back on it. So it's a hedge against non-adherence, which is really common in patients with gout. Okay, so I have some data that shows what happened to these patients in this protocol. And keep in mind, this was sort of a special clinic I set up, but the same basic procedures you can do in your primary care clinic. This is what happened to the uric acid level to the patients in this program. And I followed them over a number of months, some longer than others. And if you look across this, each one of these bars is one patient. There were about 80 patients that I was following. And you can see the range of uric acid levels. They were essentially all above 6. There might have been one exception or two exceptions. And then they were kind of all over the map. After going through the program, at the time they were discharged or the program ended, the uric acid level shown with the darker bar shows that. And the green line is 6.0 milligrams percent. This was our target. So this shows that the huge majority of these patients were actually at target after going through this protocol with my pharmacist. And what that means is that I think what it underscores is that allopurinol works really well. It essentially almost always works if patients take it. So it's just a matter of getting people to stay on it and titrate their dose. This is a slightly different way of looking at it. What this is I took a series of patients from the clinic just kind of randomly, and I plotted their uric acid levels over time. So each bend in these curves is where we check the serum uric acid. And there's a few things you can see here. The first thing is at the very beginning, over on the left side, everybody's uric acid level went down. This is another way of looking at what I just said, which is that allopurinol essentially always works. It'll always bring the uric acid level down if people take it. The initial dose typically isn't enough, and we have to titrate it. And so over time, as the dose gets titrated, more people get to target, which again is marked with the green dashed line. The other thing that I think is really interesting from this, but it reflects the reality of gout treatment, is that in a lot of these patients, the uric acid will come down and then go back up again. And so why is that? And the answer most often was that at some point the patient stopped taking the medicine. We found out they stopped taking it because we checked it and the uric acid level went up again. And so we had them go back on it and then it went down again. And at the end of 6 to 12 months, at least in our experience, the majority of patients were at goal or very close to goal, having gone through this iterated program of titrating the dose and checking for adherence. So it works really well. It always brings the level down. A lot of people stop taking the treatment. And so if you don't follow up and check it, people will not keep taking it, just like they don't keep taking their blood pressure medicines if you don't monitor it and check it. I think this is an important slide too. During my career, I would see that it was really common for doctors to put patients on either 100 milligrams of allopurinol, especially if they had kidney disease, or 300 milligrams of allopurinol, just like you'd put someone on 30 milligrams of nifedipine as a kind of a default. And what happens if you do that is that there's a fair number of patients who won't reach their target with that dose. And so what I did is I put down on this in this figure, what dose of allopurinol resulted in reaching the target level of less than 6 milligrams per deciliter. And what you see is about 65 to 70% of the patients were at goal on 300 milligrams or less of allopurinol. That's actually been shown in studies to be true. Wasn't just my experience. This has been shown in studies. They've actually done studies where they just put people on 300 milligrams and look at the outcomes. And what they find is about 2/3 of patients will achieve goal. But that means about 1/3 of patients won't. And what do you do with those patients? Well, what you have to do is you have to raise the dose of allopurinol. And it turns out that the data show that that's okay to do. The FDA has approved allopurinol in doses up to 800 milligrams. And even people with chronic kidney disease, there's no data that shows that titrating the dose up is really riskier once someone's on the medication. So I found that, I don't know, maybe a 20% of the patients that I saw needed to be on 400 milligrams. a smaller percent 450, 5, or 600. And the message from this is it's okay to keep titrating the dose, because if, really the goal is to get them to a point where the uric acid crystals in the joints dissolve, and that won't happen until it's below about 6. So you have to start people, titrate the dose. You have to follow up with checking the uric acid level, and then be, able to tell the patient to either go back on the treatment or to titrate the dose up if they're not at goal. Okay, I thought maybe I'd move on to just a couple of fairly typical cases, just to go through sort of some treatment options and what I would recommend doing in these common situations. So this first patient is a 47-year-old Chinese male. He comes in and he's had his third gout flare in the past year. He's been told about his diet, what to avoid in terms of foods, and to take colchicine when gout flares occur. He had a serum uric acid level done about 2 years ago that was 8.2, hasn't had it done since then. Medical history notable for type 2 diabetes and hypertension. He's on lisinopril as well as low-dose aspirin. And when you see him, he's got a tender, swollen left midfoot, and pain. So the question is, what do you recommend to do at this point? And I'm going to give you some options here and then try to go through them for you. First option is start colchicine 0.6 milligrams times 2, and then followed by 0.6 BID for up to 3 days, or start indomethacin 50 milligrams 3 times a day for 2 to 3 days and then taper it. Next option is tell him to stop his aspirin. Aspirin does raise serum uric acid levels modestly. So, do you tell him to stop taking that? Number 3, or C, is start him on allopurinol 300 milligrams per day to lower the uric acid level. D, have him get a serum uric acid level, serum creatinine, and HLA-B5801 gene test. And then E is tell him to eliminate red meat from his diet. So these are common options that people consider. And my approach would be to do the following. Yes, I think starting them on colchicine or indomethacin is absolutely appropriate. These are effective treatments for acute gout. And then, keep in mind that it may take more than a few days to treat this. And it's generally a good idea to have someone keep on at least some level of treatment until the symptoms are completely gone. Do you tell him to stop taking his aspirin? I usually don't. It's true that that might help lower the uric acid a little bit. I guess my feeling is if he should be on aspirin based on his cardiovascular risk, it's probably better for him overall to not stop that. You can treat with urate lowering treatment even if someone's on aspirin. So I don't normally tell people to stop their aspirin. Start him on allopurinol 300 milligrams per day. Well, he might need that, but as noted above, I would start probably on 100 milligrams and then titrate up the dose as needed. Do you have him get a serum uric acid, creatinine, and HLA-B58? Yes, I do that. So it's okay to get a serum uric acid level during a gout attack. It's often said that it can be, quote, normal during a gout attack. The data show that the uric acid level can go down a little bit during a gout attack, maybe on average 0.5 milligram percent. But usually it's going to be elevated. And so I'm going to have them get blood anyway. So I get a uric acid level. I think a serum creatinine is a good idea. And the B5801 gene, he is Chinese. His risk of allopurinol hypersensitivity reaction is higher based on the prevalence of that gene. And so it's good to get that before starting allopurinol. Generally, it shouldn't be a difficult test to get. It should only take a few days. Do you tell him to eliminate red meat from his diet? This is a little more of a question of, it's not really a yes or no answer. I try to point people away from putting too much emphasis on diet. I think, modest amounts of meat or other things in the diet don't prevent you from doing treating him effectively. So you could do that, or he may ask you about it, but it's not all that crucial. So yes, treat the gout, get the initial labs, and then after that, you can start him on allopurinol if it's appropriate, depending on the HLA-B5801. So the case 2 I'm calling refractory gout. This is a gentleman who comes in with 2 recent gout flares, one affecting the left and then moving to the right ankle. He's been on allopurinol, or he was given allopurinol about a year ago, but he stopped it a few months ago, and then he restarted it when the gout flare occurred. He took indomethacin with the recent gout flare, but he's still having some ankle pain. He has CKD, GFR 54, and hypertension. And on exam, he has a swollen right midfoot and ankle. Notably, his last serum uric acid was 5.7. That was about 6 months ago. So what do you recommend? Do you stop the indomethacin and start prednisone 40 milligrams per day with a taper over about 7 to 10 days? Stop allopurinol, continue allopurinol and start daily colchicine after the prednisone is completed. Increase the allopurinol to 400 milligrams per day. Educate the patient that he needs to continue allopurinol long-term to eliminate gout flares. And you repeat the serum uric acid level in 3 weeks. So my answer to these questions is yes, maybe it's a good idea to stop the indomethacin and start prednisone since he had a recurrence after the first bout. He's been having a lot of pain. That giving him the prednisone will almost certainly shut this off more completely and quickly, and it can be tapered and use that instead of the indomethacin. Stop the allopurinol, no. And again, stopping allopurinol during a gout attack, typically, if anything, can make things worse because it leads to more fluctuating uric acid levels. The next option is continue allopurinol and start daily colchicine 0.6 milligrams after prednisone completed. I would do that. And that's what we call flare prophylaxis, and it generally will result in a reduced risk of more gout attacks. Do you increase the allopurinol to 400 milligrams? Well, so here's the thing. He was on 300, and his last uric acid was 5.7. My assumption at this point would be that that was the result of being on the allopurinol 300, and it means that 300 milligrams was a high enough dose for him. It's just a question of him having to keep taking it. So I don't think you have to increase the dose of allopurinol. It is important to educate the patient that he needs to be on the allopurinol long-term to eliminate gout flares. And this is the point, if I'm seeing this patient, this is the point where I might mention to them about, treating things like hyperlipidemia and how the allopurinol is to prevent problems, but it really only works if you take it long-term. Do you repeat the SUA in 3 weeks? I generally would. And then again, I would increase it. I would repeat it again in about 3 months. And just to reemphasize, so many people stop their treatment just as he did. And it's just a good way of making sure that he's still on the treatment. And I would do that periodically until it's become clear that he understands he needs to take it long term. So I can take any questions. Just to summarize, treating acute gout is, there are lots of options for how to do that. Using a strong anti-inflammatory aggressively is best way to do it, to get rid of it. But managing gout is more like managing hyperlipidemia or hypertension. It's a matter of fixing the underlying issue so that you prevent problems down the line. The treatment is highly effective if people use it. I almost never have patients that can't be controlled on some reasonable dose of allopurinol. And it really does eliminate the problem long term. So if you have someone who's 30, 40 years old and has gout, you can tell them, if we do this right, you don't have to have gout the rest of your life. And you don't have to worry about, whether you want to eat some shrimp. So it's a very treatable condition, but it's best thought of as a metabolic disease that you can manage, and it can be managed perfectly well in primary care, as long as you've got a clear sense of what the goals of treatment are. Okay.
Dr. Goldfine, thank you so much for really just a well-organized and clear presentation on this topic. I'll have you stop your share if you can find the button on your Zoom. Perfect. And wanted to encourage any of the attendees to put any of your questions, and you can use the chat feature or you can use the Q&A icon on your Zoom toolbar. We'd also be interested in learning what kinds of experiences just in general you've had with patients and diagnosing them, treating them, and what kinds of patients you've been finding that have gout. So we have one question so far, and this is, what is your approach for patients with recurrent kidney stones? Concern that the etiology is due to urate composition. How would you manage?
So it is a good question. It's definitely the case that hyperuricemia is considered a risk factor for renal stones. I think even calcium renal stones, although I haven't looked at this for a while. I think it can be part of the management. Treating people with urate lowering treatment is safe, and it probably can improve the effectiveness of the prophylaxis. Just to note, you would use allopurinol, not probenecid, which increases urinary flow of uric acid. So, I didn't even mention probenecid to treat gout. It can be used. It's just a little more difficult and more limited in its use. But yes, you would use hypoxanthine inhibitor like allopurinol to treat that. And I think it's a reasonable thing to do if there are recurrent stones.
Great. Thank you so much. And Dr. Defendi, thanks so much for that great question. I don't see any other questions right now, but wanted to encourage any of the attendees. Remember that Dr. Goldfine is available on our MAVEN Project community portal in the rheumatology group. So if you ever have patients with gout, he'd be happy to answer questions, and you can specifically select him if you want him to answer your question. And he's also available for any other of your rheumatology questions as well. So it was wonderful to see everybody here today, and a huge thank you to Dr. Goldfine. If anyone has any further questions, please feel free to email me and I can forward the question to Dr. Goldfine, or you can find him on our MAVEN Project community portal. And I hope everybody has a great rest of their day and a great rest of their week.